physiotherapy after receiving her bachelor's degree in exercise science and kinesiology from Georgia Southern University. Melissa pursued her master's of science in occupational therapy from the University of St. Augustine. Melissa has significant experience with medically complex diagnosis, and her skilled areas of interest including treating neurological disorders and conditions, infant positioning and handling, and visual impairments. She's passionate about educating caregivers on prevention of torticollis, as well as treating these conditions with the clinic in order to promote independence and developmental milestones. Melissa also has therapeutic intensive and performs infant assessments for Mommy and Me services at Beyond Measure. Our second guest is Chandler Edge. After pursuing an education in early childhood special education at Mercer University, Chandler received her Associate of Science in Occupational Therapy assistant degree from Middle Georgia State University. Chandler has spent the majority of her professional career specializing in pediatrics, where her passion and knowledge surrounding the pediatric population continues to grow. Chandler has significant experience with IDEA's 13 categories of disabilities, primitive reflex integration, positioning and handling, sensory processing, and both sensory and infant-related feeding disorders. In order to continue offering specialized care, Chandler has gone to receive her certified breastfeeding specialist certification and is the founder of the Mommy and Me program, offered through Beyond Measure, a clinical approach to infant feeding and development, which is our topic today, infant feeding. So welcome to you both. Thank you. We've never had two guests on before, so this is very exciting for me.
Thank you for having us.
Yes.
So tell us a little bit about yourselves and what you do.
Okay, so I'm Melissa. I'm one of the owners, along with Chandler, for Beyond Measure Pediatric Therapies. We started January of 2022, so we're going into our 4th year. And we both just had a really strong passion for infant development and those more medically complex cases. And we wanted to be a resource to the parents in our community. So I am also a mother. I have a daughter who is 1 year old. Her name is Nora. And then we have a little boy on the way this summer.
Oh, congratulations.
And then also a wife. So we are very busy. We live in chaos 24/7 and we love it. But we love what we do and we want to share our knowledge with the world. So
Yeah. And to add to that, I'm also a mother, which we'll talk about is kind of where the Mommy and Me came from. But I have a 4-year-old little girl, a 2-year-old little boy, and then a 5-month-old.
Lord.
So we are also living in chaos as well. So I wouldn't say we're experts in all things motherhood, but we are right there in the thick of it, just with everyone else.
Yeah.
So
Amazing. I'm a mother of a 16-year-old since we're all trotting out our motherhood credentials.
Yeah.
I was one and done. So anybody can do more than one. I'm like, what? How do you do that? 3 is crazy. You guys, what's happening?
I'm gonna be honest though, 3 has been the easiest. 2 was like chaos, and then 3 is just adding to the chaos. So
You're just acclimated to
Yeah.
all of it by then. So I think that you already mentioned this, but just in case you want to say a little bit more, can you explain a little bit what inspired you to develop the Mommy and Me program within your practice and what it looks like today?
Yes. So Mommy and Me kind of stemmed from the fact that with both Melissa and I, and then also a lot of the other, most of our therapists up here are also mothers. And so a lot of our other therapists, we all had babies who just had a hard time with feeding, whether it was like bottle feeding or breastfeeding, or even just like poor weight gain, stuff like that. We all had issues, and we realized that there's not a lot of support in the Middle Georgia area. We have our pediatricians, we have IBCLCs, we have ENTs, we have all the things, but it's almost as if they just all did their own thing, if that makes sense.
Right.
And so the more that we thought about it and the more that we kind of played around with our own kids, we realized like, hey, they have these feeding difficulties because of this. So if we address this, then this will help the feeding. So that's really honestly where it kind of stemmed from. It came from our own experiences, which I think is something that's really special to the Mommy and Me program, because not only are we practitioners, we also have been there and we've been in those shoes. So we feel like that's kind of sweet to be able to offer to our moms so that they know you're not just talking to another practitioner, you're talking to someone who truly understands.
Yeah.
Um,
Where were
so
you when I needed you 16
I
years ago?
I
know.
know, I know. And another thing too is like as moms, we realized you might know exactly what to do, but when you're in the thick of it, all that goes out the door.
Yeah.
Especially when it's your own child and you think it's going to go this way, but it doesn't. So having that support to not only guide you through it, but also let you know like this is okay, you're not alone is very important. So that's the foundation of Mommy and Me. And then our Mommy and Me program is made up of a certified breastfeeding specialist or two, an occupational therapist, and then a speech language pathologist.
Yeah.
So each practitioner gets to play a crucial role in the program and the assessment and treatment of the child as well, because we're targeting the different things that all work together. So
Yeah, it's one of those things that you just assume is going to be the easiest part of
yeah,
raising a child
not.
is feeding them. Because you're
One of
like,
our therapists actually said that someone told her that feeding is the most natural, unnatural thing that a woman can do.
Yeah.
And I agree.
Yeah. Hands down.
no, it's true, and also there's an assumption that breastfeeding is like a super easy thing too, because you're like you've got a breast full of milk, you got a hungry baby, like what's the problem? And yeah, there's lots of things that can be causing issues. I know that my son had trouble latching. He was a preemie. There was like all of that. He was burning more calories than he was taking in, and it was a whole thing. And it really took us about 6 months to get it down. But a lot of people don't stick it out that long and just end up switching to bottle feeding just because it's getting food in their belly, and that's the most urgent thing that you want to do for your child is to make sure that they're not starving to death. So I know also from experience what that's like. Tell me or tell us, what does a typical development look like for an infant?
Okay, so we could go on and on about this. So we tried to kind of narrow it down. And so I'll break it down to, 0 to 3 months, 3 to 6 months, and we'll go all the way up to a year. And I'm really just going to hit the big things. So the things that affect the big motor skills and then also the feeding side of things. So from 0 to 3 months, we really want to see the infant start lifting their head when they're lying on their tummy. And even when the parent helps them get their elbows up under their upper body, starting to push through those forearms and build that upper body head control strength. Another thing is just you'll start seeing those hands coming to mouth, and that is partially reflexive. But also that voluntary motor is starting to kind of kick in. So bringing hands to mouth, and then when you position something into the infant's hand, that they start securing it in their hands, which is the foundation for the grasping skills. And then from the 3 to 6 months, we really want to see them start to push up from their tummy. So really getting under, getting those forearms under their body more independently and pushing up and being able to have that head up and turning side to side, being more aware of their environment. And then also that's when we want to see the purposeful reaching with their arms. So when they're lying and you put a rattle in front of them, they'll actually start to reach for that and start to have more of that functional play. And then from the 6 to 9 month range, this is the one that you see the most kind of start to kick in and happen. But we really want to see them start pushing up into their hands on their tummy, and even when being positioned into sitting, be able to sit and engage with the toys around them or with others. Now they still might need a little support here and there if they're reaching outside of their body's base of support, but those sitting skills really become more independent in this time. And then also they may start to army crawl, which is a great foundation to the crawling. And we talk about crawling all the time because it's such a foundation.
It's our favorite thing.
It's our favorite. And then also they can start working on just getting into the crawl position. So getting up on hands and knees and holding and even starting to reach for toys in that position. And then from the fine motor, visual motor side of things, really starting to grasp objects at midline with both hands, transferring between hands, more of those bilateral coordination skills, and even, the 6 month window, which Chandler will touch on today, I'm sure, they start to do more of the solid foods. So around that 6 to 9 month window, they'll actually start bringing that hand to mouth purposefully to finger feed. And then also just beginning to isolate individual fingers. So pointing with that index finger, and starting to develop more of a mature grasp. And then from the 9 to 12 month range, that's when we should see that infant start crawling and doing it symmetrically, which you think that's a very common, easy thing, but we see so many babies that crawl asymmetrically. So that means one side looks different from the other. And that can be a huge red flag for tension in the body. And a lot of times our babies with feeding issues, they also are the ones that we see with that asymmetry. So it's just really neat how everything kind of connects together. We can kind of get really excited about this topic. But also in that 9 to 12 month window, you want to see that infant start pulling to standing, and starting to cruise along furniture. So they're really getting more upright in their body, and controlling from head to toe. And then also for fine motor and visual skills, you should see them start learning to clap their hands and imitating you. You might see them beginning to try and wave. And then also starting to put toys into containers. So up until this point, they just like to dump things out or pull them out, but now they're actually starting to be functional and wanting to put things into a container. So yeah, that's kind of the very basic overview of typical development through 1 year. And then another side of the equation, I guess, that we oftentimes don't really touch on until you're in the OT world or the therapy world are the reflexes and how important they are in that development. And so for those of you who do not know, reflexes are basically just the response, the motor muscle response from the central nervous system. So it's how the body is responding to stimulation that has been given. And these are often involuntary. Well, they are involuntary, but they help you to produce more voluntary movement over development. So we like to see, one, the presence of reflexes in an infant at the right time. And then we also want to look for symmetry. So with some of the reflexes that we will talk about, you want to make sure both sides of the body are doing the same thing at the same time. Because if they're not, that can be an indicator of something neurological going on that we need to dive deeper or maybe even refer out to a specialist for. And then also just the strength of the reflex. That's another biggie that we look for to make sure that that body is responding the way that it needs to stimulation. And then just understanding that reflexes in general are kind of the foundation for all motor movement. So whenever a reflex is integrated and that voluntary muscle control takes over, that is leading that infant to higher level functioning. So now we're not just letting, putting a rattle in your hand and they're closing their hand and holding it. Now they're reaching, grasping it, shaking it, banging it onto the drum, whatever, that kind of thing makes it more of the higher level function that we need. So I'll stop there for now. But
to piggyback off of her, like oftentimes we think of infant development in terms of the first year of life, but we actually have to think of it as the 9 months in utero through the first year of life, because without the development of these reflexes, those milestones would not hit at the time that they're supposed to, and they might not even hit at all. So whole picture here.
Yes.
It's a lot. So we're just briefly going to touch on, there's tons of different reflexes, but we're just going to touch on the ones that we feel are most important for infant development and feeding. So the first one that we're going to touch on is the sucking reflex, which if you are a mom or a caregiver, you probably already know what that is, because an infant involuntarily will start to suck after birth. But the fun and neat thing about that is it actually develops at 21 weeks gestation. So by 21 weeks, they have that sucking skill emerging, and then it's mastered around 36 weeks gestation. And so it's mastered at 30 weeks, and then between 2 and 5 months of age, you'll see it integrate and slowly go away so that it can become more purposeful. So basically, the sucking reflex is when something touches the roof of the mouth, the infant will automatically start sucking. And as you can guess, that's probably one of the most necessary ones for feeding. So if it's weak, you will see that there's it'll interfere with the coordination of sucking and swallowing. It'll interfere with breathing while feeding, and then just like intake as a whole.
Yeah, actually, primitive reflexes is one of my favorite topics in the whole.
Oh, really?
Ooh, yay.
Questions. And I think it's one of those things that is like the most important thing nobody knows about as far
Yeah,
as
exactly.
go,
Yes.
right? Because there can be lifelong effects from these not integrating. And the way that I talk to people who use fledgling's flight, I say that when your baby's born, they don't know how to operate their body. It's a whole big bag of bones, and they have to figure out how to operate it. And the reflexes are there to help them survive until they figure it out. So the sucking
Yeah.
reflex is like getting that food in the belly, stopping them from breathing or choking while they're swallowing. And there's the other reflexes you'll talk about, like the Babkin reflex and whatnot, that are going to help them get food into their mouth and that they learn to survive. But even like everyone has got the photo of the baby holding your finger,
Yes.
and I'm like, that's a reflex. That's the whole point. That's not, they're not choosing to hold your hand. It's
But
cute.
we let
It's
that dad
Yeah.
think that that was that
Yes.
baby holding their hand.
Yeah,
And I have to giggle because as we were preparing for this, I started thinking about like integration in general, and what that actually means. And so I was thinking about the sucking reflex, and it integrates so that babies can start solids. So we like to see it integrate after about 5 months. And if you think about it as an adult, if you try to do that sucking motion that a baby does on the bottle, it's awkward. It's like, I was like, how do I do?
Yeah.
So that is a good picture of what integration means and looks like.
Um, And then the next one that's a really big one for development, but also for feeding, is the Moro reflex. So a lot of people know it as the startle or the fight or flight. And this one has always just amazed me. And outside of infants, we also see a lot of children with dyslexia, ADHD, autism, and we see this reflex so frequently in the clinic, even into their 7 to 10 years of age. But this reflex, it develops about 26 weeks in gestation. So before the baby's even born, that reflex has already started to develop. And then we want it integrated by 6 months. And I didn't say this before, but a retained reflex is a reflex that has stuck around longer than we wanted to, and typically at that 12-month mark. So every baby is different. Some might integrate at 6 months, some might be 7 or 8 months. And that's okay. But by 12 months, we want those out of the way. So if it's retained, a lot of times we'll see hypersensitivities. So we'll see lots of sensory dysregulation, oral aversions, not wanting to try new textures, or even just bringing things to their mouth. And we see that even in our infants that have a really strong Moro reflex. And then also one thing that just amazes me of how the body works together is how whenever the Moro reflex is stimulated, it is basically dumping adrenaline into the bottle. So there's the body. So the adrenal glands are firing in overdrive. And so thinking about it long term, you're looking at health issues such as asthma, allergies, all kinds of GI and digestive issues. And that can even lead to the mental health side of things like depression. So Moro is a really big one that we like to test and make sure we knock it out as soon as we can.
My husband 100% has an unintegrated Moro reflex.
Right.
A real world experience. We've been together 25 years. We've been living in our house for 20 years, and it will be him and I in the house alone. And I will walk into a room, not sneaking, normal, and I'll say his name, and he'll go, ah, and I'm like, are you kidding me? It's me. Like, who else is it gonna be? But like all the time, and he was not. For other issues, he was not handled as much. You integrate the Moro reflex by the picking up and putting down so that
Yeah.
when the hands go out, that trying to protect themselves, which still is a reflex when you trip and fall, that you put your hands out in front of you, but that's because you need it and not
Yeah.
because it's being stimulated for an unnecessary reason. So because he was not being picked up and put down as much as he ought to have been in that window of time, he still has it, and I live
Wow.
every day.
That's
We're
funny.
gonna send him a home plan.
Yes.
Thank you very much.
So the next one is the rooting reflex, which develops at about 28 weeks of gestation, and then it's present from birth until about 4 months. And that's that really cute reflex where you notice your baby going like this, going back and forth. They're looking for the breast or the bottle, and you can see that present when you stroke the side of the cheek and they turn towards that touch. And so that one's also very important for feeding, especially in the newborn days, because their vision is not that great early on. So it helps them locate breast or bottle. So when it's weak or it lacks, it interferes with head control, sensory regulation, feeding, and then just exploring their surroundings.
Amazing.
And the next one is Palmer, which we already kind of talked about this one, but basically that's the involuntary. So whenever something's placed in the hand, or like we test it by putting our fingertip into the baby's palm, and they'll just close that hand around it. So that one should be present until about 6 months of age, which, like I said before, that's when they start bringing food to their mouth and really doing that functional play with toys. So we want that to be out of the way so that they can gain those grasping, grip strength skills that they need. So, and if we see it retained, a lot of times those are the babies or the kids that have difficulty with handwriting, holding a spoon, tying their shoes, buttoning, fasteners on their clothes. They have those delayed fine motor skills. So,
And the next one is a mouthful. So it's called the tonic labyrinthine reflex, but for this purposes, we'll call it the TLR. And that one is present from birth until about 4 months, and then it actually will reemerge. And then we like to see it fully integrated by 3.5 years. So it'll reemerge to help with some of those higher level skills like crawling, sitting, gross motor, all those things. But this one is really big for postural control, and then also gaining head, neck, and trunk strength. So basically this one you'll see when a newborn or a baby brings their chin in towards their chest, they'll go into the fetal position, and then just like going into the fetal position, the opposite will happen. So if they bring their head back, their whole body will go into extension. So arms will go straight and legs will go straight. So.
okay. And then the next one is another mouthful, so we'll use the acronym, but it's asymmetrical tonic neck reflex. This is another one that I love and that we see all the time. But this one is also known as the ATNR or the fencing reflex. And I don't want to punch Chandler, but it's basically like if you turn your head to the left, your left arm is going to go into extension and your right arm is going to be in flexion behind you. So it really helps a baby learn that depth perception and the hand-eye coordination. And we really want that one gone by about 6 months of age as well. But we really won't consider it retained until after 12 months. So earlier the better, but it does help to gain the hand-eye coordination. So if you have a rattle in your hand that's extended and learning to bring it closer to your eyes, you're building that, oh, this is coming closer to my face. So it can be a protective thing, but also can lead to the coordination skills you need to crawl or to reach across your body and build those crossing midline skills. And then as far as, what we look at in the clinic as well, we have to really think about, well, sorry, I thought that was silenced. Okay, should I start ATNR over or should I?
Yes, please. Yeah, go ahead.
Sorry. Okay, so the next reflex is ATNR reflex. And that one is asymmetrical tonic neck reflex. So it's a mouthful. But that one is also known as the fencing reflex. So when a baby turns their head, their arm is going to go into extension in the direction they're turning, and the arm behind them will be in flexion. So it kind of looks like you are fencing. So we want that one going by 6 months of age. But like I said before, if it hangs around till closer to 12 months, that's okay. But we do want it gone before that, that 1 year age mark. And this one, a lot of times, can help with the depth perception and hand-eye coordination. So whenever that baby is reaching their arm out, they're learning when that hand comes closer to their body, which is also a huge thing with safety awareness. And then another really cool thing about the ATNR is that it's one of the reflexes that actually helps the baby through the birth canal. And so it works alongside the spinal galant, which I don't think we actually go into detail of that one today. But it's another one that we do assess in the clinic, but they work together to help that baby through the birth canal during a vaginal delivery. So these C-section babies, a lot of times they don't ever get to utilize that reflex. So a lot of times if I see a medical history of a C-section, I'm automatically testing ATNR and spinal galant because the body didn't naturally get to use those. So a lot of times they like to hang around. So,
yeah, and the interesting about the spinal galant, which I know that you just said that you're not going to talk about, but I will, because there's like this crazy thing is that it's associated with bedwetting, right? Because
yeah.
stimulating the spinal cord, so a child's hair brushing the back or a sheet or something. So sometimes that people who have children who have bedwetting is not a psychological issue. It can be an unintegrated reflex. And so I think that's something that's really important for people to know.
Mhm.
And
Yeah.
and there's also like a hot tip for potty training, right? With especially an unintegrated reflex, right? Because if you stroke one side of the spine, the body kind of curls one way, and you stroke the other side, and the other side curls in. But if you, what I've been told, if you do two fingers down the center, they wet themselves. They pee.
Yeah.
Mhm.
I've had students that were learning how to test and actually stimulated a child to urinate. So
Yeah.
it is true, it works.
Yes.
And on a tangent with that, just if we ever have like a 5-year-old who's been potty trained, come in with a referral with concerns about bedwetting, if they're at that 5 or 6 year range and they were already potty trained before day and night, and all of a sudden it's resurfaced, then typically the spinal gland can play a big role in that. Now, sometimes it is psychological, but sometimes it's that reflex, and once we knock it out, it's great.
Mhm.
So
Yeah.
just some food for thought for parents out there.
All right, and then we have one more, and it's really short and sweet, but we're going to touch on it because we have mentioned how we love crawling. So, the last one is the symmetrical tonic neck reflex, which is STNR, and this one's present at birth, and then you will see it reemerge around 6 months, and be there from about 6 months to 11 months. And we like to see it integrate at 11 months, but this one is very important for crawling. So if it's retained, it can result in low muscle tone, lack of postural control, lack of body awareness, hyperactivity, and then poor hand-eye coordination. So that's just a little sad one.
Yeah, and I think I mentioned it earlier, but you haven't talked about in depth the Babkin reflex. So
Yeah.
that bringing
Mhm.
the hand to the mouth, so learning to self-feed. That one
Mhm.
also has a lot of associations if it doesn't integrate with eating disorders, right?
Yeah.
Yeah.
Yes.
And so
Yeah.
sometimes, again, it's not a psychological thing, but it could just be an unintegrated reflex.
Mhm.
That's
Yeah.
why I think they're so important for people to know about.
I know.
So now when I meet people that are highly anxious, I'm like, maybe your moral reflex hasn't integrated, your fear
Yeah.
paralysis is still activated.
Yeah.
So I'm always self-diagnosing people, and I don't even have any credentials.
Well, you have a lot of knowledge
Yes,
just
you
from
do have
what
a
you
lot of
do,
knowledge.
though.
Yes. And before we go into feeding development, Melissa is going to briefly touch on just some things that can cause these reflexes not to integrate, because that's also really important to know,
Yeah.
especially when we are doing an evaluation or a treatment session.
Yeah. And so, this is a very shortened list. There can be so many factors that play a role. Every delivery of a child is different. That experience is going to be different for every infant. The genetic makeup of a child, everyone is different. That's why we're unique. And then also just the presentation of what we're seeing in the clinic is also going to be unique to that child. So this is a very brief overview, but it's a lot of the big ones that we see the most often. And it's what she said, the ones that play a key role in why these reflexes may be retained. The first one is genetics. So if there's something genetically, whether it's a deletion, an addition, whatever it may be, genetics can play a huge role in those retained reflexes. Another would be if there was any sort of incident at birth, any kind of traumatic brain injury, or just a delayed delivery. So if that baby kind of gets stuck and takes a little bit longer to deliver, anything that causes a disruption in that process can be a result of this. And then also induced labor and also prematurity. So like you said, with your child, prematurity can play a huge role because as we discussed all of these reflexes, a lot of them start to develop in utero. So if you don't get that full time in utero, they don't have the full time to develop and become more mature the way that the body intends for them to. And then really the last two that we talk about a lot are the lack of tummy time.
Yeah.
So, the babies that are placed into containers are not given that opportunity to move and get that weight bearing onto the floor on their tummies and arms. A lot of times we can see those delayed reflexes there because they don't get what they need early on. And then also the skipped crawling milestone. So
There
back
it is
to
again.
crawling. Crawling is the foundation for bilateral coordination. And so we need the body needs to do that for more than just that, but also for posture control, for sensory input. Think about how much input the palms of the hands are getting with every step they take crawling. So all of those play a huge role in it. And I actually think I skipped over C-section delivery, but that one is a huge one, like I said, with the Moro reflex or the ATNR. Any C-section delivery baby, they aren't getting to use those reflexes during birth. And so a lot of times they're kind of hanging out longer than they should because they're like waiting for their turn. They don't ever get it. So we have to teach the body through programs and things to help them integrate more naturally. So
Yeah.
One thing I just wanted to clarify for those people who don't know, bilateral coordination, there's an imaginary line that cuts your body in half, separates your left side from your right side, and also separates your upper body from your lower body, and you need it to walk, right? So you don't walk with your left arm and your left leg and your right arm and your right leg, you know, like that alternated. And so you need this coordination to crawl and walk and ride a bike and swim and all these things. So there's symmetrical, which is like clapping your hands, and there's asymmetrical, which is like opening a jar. So one hand is holding, the other one's doing something different, supporting it. So you can add to that if you'd like, but that's how I explain it to
yeah, that's great. Yeah, that's a
That
beautiful
is
description.
beautiful,
Yeah.
yes.
And then too, as OTs, we love to see babies and children crossing midline. So going across that imaginary line to help build those connections and helps up the processing speed with higher level thinking and all those things. So yeah, bilateral coordination is another one we
Yeah.
could get really
Whole
excited about.
So we just went over a ton of information on
Yes.
development, but all that was very important because now we talk about feeding and feeding development. So if we assume that you have a typical delivery, everything goes as planned, baby's term, delivery goes well. Usually, right after delivery, the mother is given the option of skin to skin. So, skin to skin will happen, and the babies, whether it's breastfed or bottle fed, are expected to eat within hours after delivery. So, that happens. And then, after that, newborns within the first 2 weeks of life are expected to eat either on demand if breastfed or every 2 to 3 hours if bottle fed. And then we hit 2 weeks. So, then from 2 weeks to 5 or 6 months of age, they're expected to eat every 2 to 4 hours. And like we said, no baby is the same. So where one baby might be eating every 2 hours, another one might be eating every 4 hours, and that is completely normal. And intake might not be the same, and that is completely normal as well. So then we hit 6 months, and at 6 months, if baby demonstrates good postural control, good head control with upright sitting, and it can be supported sitting, just they need that head control. Usually they're given the go-ahead to start solids. So they'll be able to start solids, but breast milk or formula is still considered the primary source of nutrition. So those will go hand in hand together. So that is what typical feeding looks like. But as we all know, feeding is not always typical.
Feeding is hard.
And so we'll touch on that, but we'll see those reflexes come into play during all of those 6 months, 12 months of life, because like I said, after birth, skin to skin happens, and a lot of times you'll see what we call a breast crawl. So the infant's going to try to locate the breast, and when they do that, you'll actually see the majority of those reflexes. So you will see ATNR because they're trying to get to the breast. You'll see Palmer because they're grabbing at everything that they can to get to the breast. You'll see the rooting reflex. You'll see the sucking reflex, and then you might even see the Maro reflex because all these different sensations are hitting them at once. Because they've just been snug in your tummy. So that's really your first glimpse as a parent, seeing all those things come into play. So after the breast crawl happens, they'll have to latch on the breast. So you'll see rooting, you'll see sucking, you'll see what is called a suck, swallow, breathe pattern, which helps with sensory regulation. And then after they latch for the first time, they keep latching again. So you'll keep seeing these things happen. You'll see Palmer, rooting, sucking, all those things. We also have to think about positioning. So when a baby is nursing or taking the bottle, they want to be comfortable. So they'll have to have good postural control, good positioning, good support. You want to make sure that their head is supported, their trunk is supported, they're comfortable, you're comfortable. And then a baby also uses sensory regulation while feeding. So if there's sensory stimuli that's making them uncomfortable, your feeding experience is not going to be good because they're going to get mad, you're going to get probably overwhelmed and overstimulated. So that's why all these reflexes are so important for feeding, and why these developmental milestones are so important for feeding. And as a first-time mom, you probably don't even think about those things.
Yeah.
So that's what we're for. You probably just think I'm lost and I don't know what to do. Um, so that's for a typical delivery, and that's what we expect to see. But like we said, that doesn't always happen. So with the Mommy and Me program, and then also just with typical like OT referrals, speech referrals, we look for red flags that can indicate feeding difficulties. So when we think of feeding, we think of it as a whole body experience. So whether it's breast or bottle, basically your baby is using every system that they have to coordinate feeding. So they're using postural control, they're using their muscles, they're using oral motor skills, they're using their GI system, their respiratory system, their nervous system. So all the things. So if there is a disconnect with that, feeding is not going to be easy. And development might be delayed as well. So some of the red flags that we look for in a newborn are tension, and that can be present in the body, but it can also be present in the mouth. So you could see an oral tie or a lip tie or even a cheek tie, which is basically just when there's skin. So there's like this little flap of skin that can connect your tongue to the base of your mouth, your lip to your gum, and then the same for the cheeks. And that's usually a big sign that there's tension. We look for tension, oral ties, and mom, we look for pain with feeding. So if there is tension, nursing's going to hurt. If you're bottle feeding, they're going to spill. They might have gas. They might have reflux. We look for, is your baby satisfied after feeding? Because if they're working really hard, probably not going to be satisfied after feeding. Are they gaining weight? Because again, if they're working really hard, they're burning all those calories, which I know you had said that was the case with your son. We look for, is there reflux? Are they noisy? Is mom getting frequent mastitis or clogged ducts? Because that indicates probably a latch issue, and then slow weight gain. So that is for not typical feeding.
So what is the connection between infant feeding and development?
Which we briefly I just touched on that a little bit, but basically, like I said, feeding is a whole body experience. So in order for a baby to feed efficiently, they're using all of these systems that also interfere and interact and influence development. So they're using their respiratory system, they're using their digestive system, they're using their motor systems, they're using their nervous system, which regulates reflexes. They're using muscles, endurance. They need all these things, which also you see is needed for development as well. So really, if there is a delay in development, there might be an issue with feeding, or feeding might be a cause for delay in development.
So what can be done if there's a disconnect between the two?
So if you're local to us in Middle Georgia, you can come to our Mommy and Me program. If you are not, then we always recommend discussing with your pediatrician, just the options that you have in your area. Look for the resources that are present. So we love collaborating with IBCLCs or lactation consultants. If there are oral ties in their mouth that could be hindering feeding, then a pediatric dentist can be a great option, or a pediatric ENT, just depending on the issues. And then honestly, sometimes the greatest thing you can do is just ask for an OT or a speech and feeding referral, and try and see if there's more going on than what's being able to be seen in the pediatrician's office. Because I mean, we love our pediatricians. They are huge advocates for us, and we advocate for them. But they're in there for only a few minutes at a time, and we're actually watching that entire process of feeding or movement. We're assessing the full body picture. And so sometimes we can get a little bit more in depth as to what's going on, and then coordinate with them. So we always recommend seek out the resources you have in your area and use them, because, and we'll go into this later, but also we never want someone to walk this alone. It's
Yeah.
a very isolating thing to be overwhelmed with your newborn who is screaming at you. You feel like screaming, and feeding is just not working out. So don't do it alone.
I hear you. I mean, I think I still have post-traumatic stress disorder
Mhm.
from
Right.
having my
Oh,
child.
yeah.
And you
Right.
wonder why I only had one and not, and not more. So I know we talked about this a little bit, but what can the result be if these things are not addressed properly?
A lot. So if these things aren't addressed, obviously feeding difficulties, whether it's breast or bottle,
Mhm.
there isn't just an issue with feeding difficulties, but also the progression of feeding. So starting solids after you've met those milestones, you might not meet those milestones, so solids can't be started at that time safely. There might be issues with oral motor skills, so teeth, you might notice issues with your teeth, you might notice speech delays, and then just weakness in the mouth, in the face, and then also social emotional insecurities from PTSD, all the trauma, and that's for mom and baby. So, and then just breathing issues as well, because with feeding, you have to be able to regulate that. So, and those are just some of those. Those are the biggest ones that we see.
And I'll piggyback off of that. She talked about tension in the oral region for feeding, but the great thing about our program and getting to work with a speech therapist, a CPS, and an OT is that we're looking, like we said, at the full body picture. So when you're assessing the tension in the body, a lot of times you will see a preference to one side. So if your baby only wants to nurse on the right side, or when they're laying on the floor, if they're only turning their head in one direction, that can lead to, if it's not already, torticollis, which is basically tightness on one side of the neck. And then also that can lead to plagiocephaly, which is head shape, changes in the head shape not being symmetrical. So you might start seeing flat spots or even ear or eye shifts when they get more severe. So things like that we really like to look out for. And then also, ways to identify that tension. If your baby just seems uncomfortable and you can't figure out why, like they don't like the car seat, they don't like to be held, nothing seems to make them feel satisfied. A lot of times that could be tension, or also shoulders up here all the time, or wanting to keep their hips into extension, legs out long and holding their body. A lot of times that can show there's stress in the body that needs to be released. And so that's where we can also come in. And then also one thing too would be when you see them in a car seat, if that head is tilted or just sitting upright. If they're keeping their head like this a lot of times, that's a sign that there's some tension in that upper body, and it can go all the way through the trunk. So we look head to toe where that is coming from and how to stop it. So one
And
good,
also uncomfortableness in tummy time too, right? So
Yes.
absolutely,
hip flexor. And so, yeah.
yes. If your baby hates tummy time, yes.
And two, we didn't mention this, but another great tool to have is a chiropractor.
Yeah.
So they can help with tension and then just like releasing the gas and then the air. So that's another really good tool to have in your back pocket.
Finding one that
Take,
specializes in the pediatric side of things. Yeah,
takes a village.
it does.
We can survive as a species without 10
That's
specialists.
right. That is right.
Okay, as an occupational therapist, what is your approach to assessing an infant and how do you plan for treatment?
Okay, so coming from the OT side of it, for example, I'll kind of just set the stage for a mommy and me assessment. So when that mom and infant comes in for the first test or for the first consultation, we always start with just parent interview. So we're asking mom, what's going on at home? What are your concerns? What questions do you have for us? And then I always like to get kind of a picture of their day-to-day routine, how they like to position when they're feeding. I look at, home environment factors, and also just the medical and birth history that can play a huge role in kind of how I gauge my assessment process. And then typically from there, I go into assessing range of motion. So I look, like I said, at the neck, shoulders, elbows, hands, trunk. We look a lot at like the trunk rotation and being able to kind of shift our hips side to side. We call that lateral extension, and then also just lower body range of motion. And usually while I'm doing that, the CBS and the speech therapist are doing the maternal assessment. So they're looking at issues with mom with the breast, or what, more of the physical side of things for mom. So we're kind of tackling two birds, one stone. And then also I'm looking at the cranial shape. So looking at head shape, has it been affected? Are they at risk for it becoming effective? Do I need to educate on positioning and stretches? And a lot of times I'll send that mom home with range of motion home plans from the first day, because the sooner we can address it, the sooner we can get it out of here. And unfortunately, with cranial shape, once you hit that 4 to 5 month range, there's really not much that therapists on the intervention side can do. A lot of times then we have to go to further things as far as a cranial helmet if the parent really wants that head shape to be perfect and beautiful and round. So we like to try and get them in as soon as possible. And then I also do a reflex screening. That's another really big one that we like to make sure we do. So, yeah.
Yay. So what does typical treatment look like at the clinic?
No, it looks different for every
Every
child.
child.
But typically we will start that treatment with range of motion. So we will go through stretching the body, seeing where the tension is, and that can change day to day. But if they do have a preference to one side, a lot of times we can kind of assess with each treatment visit if that's improving or if it's worsening and we need to change things up. So we do a lot of the range of motion, and a big part of that is parent education. So I get that parent down on the floor with me and I say, okay, I'm going to do this, then you're going to follow me so you can put your hands on them and see how it feels before you go home and you're like, wait, what did she just do? So I do lots of parent education throughout the entire treatment. And then also a big thing, and Chandler mentioned this with sensory stimulation, is we like to set up the environment to what's best for the infant. So sometimes we need to dim the lights or play some, white noise or some music. We try to make it a very calming, natural, comfortable environment for that baby. So sometimes just educating the mom on, hey, maybe when you're in these early days, don't feed your newborn with all 4 children running around you at the house with the TV blaring. Like sometimes you need to, kind of change your environment to help them feel more comfortable until they gain those skills. And then also we do lots of strengthening. So if that baby is tight on one side, that muscle has not been able to lengthen, and therefore it couldn't be strengthened until we get the full range. So a lot of strengthening exercises, putting them in different positions. And then while Chandler is working on them with feeding, I'm addressing positioning and seeing, oh, well, let's try and do it on that non-preferred side today and seeing if we can make some progress with latch. So things like that. Every treatment is different. That's just a quick little overview of what it could look like.
Fabulous. So what 3 pieces of advice would you give to a mom that is concerned about her infant's development or has feeding difficulties?
Ooh, we could give a lot. I would say, like I said before, never feel like you have to walk the journey alone. It can be so overwhelming and defeating. And if you truly want to breastfeed your baby, or if it's bottle feeding and that's what you want to do, both are wonderful options. And so we don't want you to feel like you're alone in that. So we say reach out to the resources that you have in your area and have some community help walk you through those early months.
Yep. And then also, whether or not you choose to breastfeed or bottle feed your baby, and whether or not it comes naturally or it doesn't, we want to remind you that you are a great mom and you are exactly what your baby needs, and you have your baby's best interest in mind. So how you feed your baby does not define your baby or you, and you are doing enough for your baby.
And then the last thing is just if you go to your pediatrician appointment or you are at home and you get that gut feeling that something is just not right, whether you've been told to let's just wait it out and see, or it's hard in these early days, let's just let the baby figure it out on their own. If you have that mama gut telling you, knows there's more to this, there is something wrong, then push for what your baby and you need. Advocate for yourself, because we've been there and we hear it all the time. Just wait and see. And those are my least favorite words I've ever heard. So if you have that gut feeling and you know that there's more going on, trust yourself, because you are the mom, you know your baby more than anyone else. And that's how we encourage all of our moms to be. Even if they go home from us and they're like, ooh, I don't know about this, come back to us, because we want to help you figure out what's best for your baby, because you know them far better than we ever could. So
Amazing. Well, that was a lot of information.
Yes.
Holy people are gonna have to watch this like 4 times just
I
to
know.
everything.
And that was just like a pinch of it.
Yes.
Oh, it's such a vast thing. And the thing is that nobody goes to college to have a baby.
Yeah.
Right.
They just have it and everyone makes it up as they go along until they, until there's a problem and then they seek out a specialist. And that
Mhm.
is, but we made it as a species this far. But
Yeah, we're doing great.
so let everyone know how to get a hold of you guys.
All
Okay.
right.
You can reach us through our website. So it's www.bmpediatrictherapies.com. Or you can also shoot us an email.
Mhm.
Our email address is info from information. So info at bmpediatrictherapies.com.
And if you look up our website, all of our handles are on there, our phone numbers, all the things are on there. But we also have an Instagram and a Facebook, and it's just Beyond Measure Pediatric Therapies.
And so they could DM you if they have any questions.
Absolutely. Yes. Yes. And we love to post.
DMs.
Yes, we do. And we love to post educational content. And if we have a mom that brings a concern to us, then we say, we're going to make a post about this because you're probably not alone in
Yeah.
that. So follow us on Instagram and Facebook. And we'd
Yeah.
love to meet with you.
Mhm.
Well, thank you for your time today, and thank you all of you who have sat through and learned so much information with us today. And we will see you next time. Bye.